So my name's Dan Leff. I'm a reader in surgery here at Imperial. Welcome everyone to the workshop this afternoon, so robotic endoscopy at scale. So in this workshop, we're going to hear quite a lot about the challenges of endoscopy at scale. And we're also going to hear about some of the developments from our speakers regarding navigation and flexible access in different fields, including fetal surgery and for bronchoscopy. So without further ado, it's a great pleasure for me to introduce our first speaker. That's Mr. Gerald Gwee. He's a consultant surgeon at the Royal Marsden, and he combines a very busy and complex surgical and reconstructive practice with research. He has many areas of interest, but he is, it's true to say, one of the leaders in the field in terms of pushing the intraductal approach, the endoscopic approach to breast diagnostics and therapy. And it's really a great privilege for us to have him present at this workshop. So without further ado, Mr. Gwee.
Just sharing my screen.
Just as you're sharing that, I should just tell those that are listening in, they can ask questions via the Q&A chat feed. We will take questions at the very end at the panel discussion. We'll try and ask as many as we can.
Okay, so the first disclaimer is that I don't have any robots in my talk. And as Dan has said, the reason why he's asked me to present this is that he's adapting this technology to kind of more modern approaches to duct endoscopy. And he's asked me to share the challenges and experiences that we had when we ran this program between 1999 and 2016 at the Marsden. The concept is, I would say, ideal because it's the evaluation of the natural internal environment of an organ. In this case, in the breast, the fluid is in direct contact with the tumor. And if you're looking at evolution of the tumor, it's the immediate environment in which case, in which this changes occur. In order to do any kind of ductal type work in the breast, you have to be able to access the ducts. It's not an organ like the lung or the colon where the orifice is obvious. And this is one of the kind of greatest challenges, I would say, in duct endoscopy of the breast. So if you can't identify the fluid yielding duct, you haven't got a program. So in order to identify the ducts, the simplest way of doing that is to either massage or manipulate, but often especially in postmenopausal women, it doesn't work. And you need some kind of aspiration device to be able to suck on the nipples to be able to get some fluid to appear. So you can see here, the nipple aspiration cup is a very simple device. It's got a docking station to allow a simple syringe to be applied. You pull back 5-10 mils of negative pressure, and often you get a number of ducts, typically up to 4. So the fluid that forms then gets pooled. The volumes are very small. So we're dealing with microliter amounts. A kind of typical volume will be 10 microliters. A problem with storage and small cell numbers. And as patients get older, postmenopausal patients, it's hard to get the fluid. And of course, cancers happen in older patients. The material tends to get pooled. And these are some limitations of nipple aspiration as a means of addressing the internal environment of the breast. The next level up is ductal lavage. So this requires an intervention into the patient. It's no longer just a matter of identifying the duct, but it's a matter of being able to, as you can see in this bottom left picture here, cannulate a duct in an awake patient. And the device is pretty straightforward. It's a blunt needle. It's got an afferent catheter and an efferent catheter. So saline is infused down the afferent catheter, and we pull back and get the fluid back. And instantly we are changing the landscape because we're now looking at specific duct fluid. We're looking at situations whereby the cell numbers are significantly higher. But the only limitation here, I would say, apart from the intervention, is that we're now talking about dilutions. And it's not always the case when you put in 10 mils of fluid, say, that you'll get 10 mils of fluid back. Nevertheless, cell counts in duct lavage go up to 10,000 to 100,000. Cell counts in nipple aspiration are down to maybe 10, 100 if you're lucky. And with a competent pathologist, we're able to identify diagnostic type categories. So C2 is a normal duct epithelium. A C1 aspirate usually means that you've not got enough cells to make it meaningful. You can see here the cells become more abnormal as they become atypical and malignant cells with large nuclei. One of the limitations of this is the cell purity. It's not always the case that you get pure cell population. So here's in the C3 cluster, these are called papillary clusters. So they are kind of cells that kind of just fall off the inside of the duct. And these are normal cells, but you can see that they are kind of contaminated with macrophage cells. And sometimes these macrophage cells can occupy quite a large amount of the cell count. The next level up is the duct endoscopy. So these were the three things that we said a few slides ago that forms the underlining concepts of duct of the introduct approach. So nipple aspiration, duct lavage, and duct endoscopy. So this is a third of them. This endoscope here was the first one I got in 1999. You can see it's a flat screen, and it was an analog recorder. And this is the last one that I got in 2010, flat screen and a digital recorder. The endoscopes themselves are pretty simple. They've of course undergone changes too, but essentially there's an endoscope that is that looks like this, labeled B here. The external diameter of this endoscope that is shown here is 0.9 millimeters. So a smaller scope would be 0.7, a bigger scope would be 1.3. And what makes the scopes bigger are the number of working channels. So there's one working channel here. The fiber optic goes down this. The fiber optic diameter is only 0.3. And this is a shifter which allows you to place the scope anywhere along the shaft so that you can protect the tip of the fiber optic. The potential applications are shown here on the left panel, but how to achieve it is really what I want to talk about, which is shown on the right panel. The majority of work has actually been done on biomarkers. So biomarkers, in essence, are either predictive or prognostic. So what that means is if you have compound X, and compound X is identified in a breast duct or a breast segment that contains a cancer, that's a predictive marker. If you've got a marker that is a prognostic marker, it's usually one that says if compound Y is identified in the cell duct fluid, then that's associated with the prognosis, which is better or worse. So a lot of work in the introductory approach is actually around biomarkers. In this talk, we're going to focus more on the endoscopic side of things, which is visualization, and then a biopsy. Visualization alone is pretty hopeless. To biopsy something, either we have to use a device that marks where you've seen, and I'll show you some of these in my talk, or you have to use microendoscopic equipment, such as a small pair of biopsy forceps that goes down that tiny channel. And the holy grail of all of this is to try and use it in some kind of therapeutic purpose. And we can talk a little bit about that, but most of the developments in therapeutics is duct endoscopy has been in benign disease and not in cancer. So we don't have a lot of time to talk about biomarkers, and I'm only going to mention this in this one slide. So there are various targets. Whole cell was probably the most simplistic and what began the introductory approach in the 1990s. It was mainly cytology and simple staining, Nicolau type staining. But I would say the bulk of the exciting work was done on the molecular approaches, mainly the DNA type work, proteomic type studies, multiplex systems. And I would say that's the majority of publications in the biomarker field in the breast. There are some studies on RNA, but it's much more difficult medium to work with. RNA is generally unstable, and so it's not such a wide amount of literature on RNA. And of course, then there are the biochemical products, either proteins or carbohydrate antigens and so on. But the problem with each of these is that there's limited sensitivity and specificity. Whether you use a single marker or panels, in general, the power of the biomarker isn't enough to drive either a predictive or prognostic intention. So with endoscopy, although there are 6 to 12 true duct orifices on the nipple, there may be only 2, maybe 3, sometimes 4 accessible ducts to insert the endoscope. So therefore, a typical successful duct endoscopy will involve a minimum of 1 first-order duct. And if you have a more successful endoscopy, you might be able to inspect up to 10 ducts, but these are branches of the 2nd, 3rd, and 4th-order ducts. So a normal breast will have smooth, white epithelial surface, no stranding, no red areas, no raised areas. And you can see that each of these branch orders can divide into two, sometimes more than two second or third degree ducts. There is a practical problem in identifying which ducts have already been inspected. And even if you go down the same duct system twice, it's often difficult to know whether you've been down here before. And this is particularly so when you return for a second endoscopy. It's not easily reliable whether you're seeing the same duct or not. This is a papilloma. It's a benign structure. It's the commonest cause of benign nipple discharge. There's blood stain. You can see it's red, it's fleshy, it's polypoid. And the pathology on the right shows how, when they form, they invaginate the basement membrane and the lamina propria, bringing with it a blood vessel, and therefore they present as bleeding nipple discharge. But ultimately, these are benign. Duct ictasia is another very common situation. You can see in the X-ray, the ductogram here, where we've cannulated the duct and instilled some dye, some radioactive contrast. You can see that these ducts are now broad and quite wide. And this is the easiest type of duct to do duct endoscopy in, because it's a kind of broad chamber, and it's generally straight, and it's easy to drive the endoscope down a ductic duct. The only trouble with that is that it's often got lots of debris in it. It's often the need to wash out the fluid to be able to see the epithelium, and often you can see some calcification at the edges of the duct. It's perhaps more clear on this inset here, but duct endoscopy for duct ictasia is probably the easiest of accesses. We're now going up the ladder towards cancer. So this is a form of epithelia, hyperplasia. It's now known as flat epithelial hyperplasia. The more abnormal these things become, the more raised it is, but you can see some red patches appearing as we go down this duct. This is also known as atypical intraductal dysplasia, and this is the beginnings of cell change that turns into a malignant process. DCIS stands for ductal cancer in situ. So this is a type of tumor which is the pre-invasive form of breast cancer. It hasn't invaded through the basement membrane, and you can see that there's a papilloma in the background, and these are sometimes associated with ductal carcinoma in situ. And the more prolific the ductal carcinoma in situ, the more frond-like it becomes, and the more vascular it becomes. And with high-grade DCIS, it's often the case there is contact bleeding. Cancers are perhaps the most challenging, because there is, beyond the cancer, the post-distal obstruction. That means the duct between the cancer and your access point, the nipple, is often collapsed. So trying to get into these ducts can be very complicated. These are the most challenging forms of endoscopy. And the ducts are often destroyed by the cancer. So you don't generally get to see the cancers. And it's easy to perforate. You can see here this kind of angel's hair type appearance has occurred because of a perforation into the epithelial lining. So the limitations in duct endoscopy, the primary problem, I would say, is the number of orifices. It's an organ with multiple orifices, and you'd be lucky to be able to cannulate, I would say, 3 or 4 in a good endoscopy out of a possible 9 to 12. So the access to the orifices is an issue. The distance from the nipple opening may also be an issue, especially when you're trying to cannulate the duct and see something that is very distal in the tree, perhaps even at the base of the nipple. And the distance from the nipple opening is also limited by the length of the scope. So the typical scope length is 7 to 9 centimeters. If you have a very big breast or the lesions in the periphery, you may not be able to get there. We've already mentioned the distal obstruction that may impede duct access. And one of the other encounters that we felt was a problem was sterilization services. Somewhere around the mid-2010s, there was a change in heart about sterilization services that allowed us to reliably clean endoscopes, especially the microscopic working channels. And this created a kind of a big game changer, because it suddenly required us to change our entire equipment tray. It's of course cost extensive and labor intensive. So now I'm going to turn to some trials that we did and to see how some of these things applied to clinical practice. So Intent 2 was a trial of a randomized control trial to assess the value of duct endoscopy as an adjunct to standard surgery for pathological nipple discharge. So pathological nipple discharge means discharge coming from the nipple from a woman, and it's persistent, and Persistent usually means it's been going on for a while, two to three times at least a week. And the reason why we do surgery to this, especially in the kind of older or postmenopausal type situation, is that there's a higher chance that this would be associated with a cancer. So pathological nipple discharge may form about 10 or 15% of referrals to a typical breast clinic, but may only form 5 or 10% of cancers. So once the surgeon had made a decision that surgery was indicated, they were randomized into either getting standard surgery or duct endoscopy guided surgery. The endpoints we used were, if they were in the duct endoscopy group, how successful was visualization, and to compare that with the pathological findings. In the two groups, duct endoscopy and non-duct endoscopy group, was there a difference between the pathological yield rates? And finally, to compare the resection size. If duct endoscopy is a more targeted operation, would we do smaller specimens? So I'm going to show a short video of a non-directed duct endoscopy, a non-directed duct excision. So this is, in essence, a blind operation, because all the surgeon has done here is put a lacrimal probe, that's this white thing sticking out of a duct, that has gone down a first order duct. These ducts generally are dilated, which means that it could have gone down any duct, it could have gone down the wrong order duct, it could have even have perforated, but the purpose of, or the target for the surgeon is just following the kind of rod all the way down. He's not sure what he's cutting, so ultimately he ends up taking a bigger specimen, and where you end up cutting is also a kind of slightly random decision. You get a specimen that looks like that, and you hope that the pathology is within it. Oops. So this was our attempt to try and make the procedure more localized. So you can see the endoscope here. This is the working channel, and this is what we call a rhomboid. It's a device where if you push it down a narrow channel, this retracts back, and so it becomes a kind of flat wire. Whereas on the other hand, when it is open, it has a 3D component. And if we get the video to start, you can see how it kind of goes back into a wire form when you push it into the working channel. It comes out the other end of the working channel, and re-expands. And because you would have seen your target in the duct, you can open under direct vision the rhomboid and leave a very specific target for the pathologist to look at. So once you've identified that and left the wire in the correct place, you have to withdraw the scope. And with that, you've turned an untargeted operation into a directed operation. It's then easy to follow the wire down. You know that whatever you're cutting is in the correct order duct, and you would finally end up with the depth being marked by the rhomboid. And you get a specimen that looks like that. So did this all work out in practice? So this is a standard 2x2 table for assessing sensitivity and specificity and so on. So the rows represent whether the duct identified a lesion, yes, or duct identified a lesion, no, and whether this was identified on histopathology, yes or no. So we have these figures here, which would be the true positives identified on endoscopy and identified on histology, the true negatives not identified on endoscopy, not identified on histology, the false positives and the false negatives, and so on. So what we could conclude from all of that is that duct endoscopy was reasonably sensitive and reasonably specific with their corresponding predictive values to allow us to use it as a technique to identify a lesion. Good, but did that make any difference to the patient having the operation? So to answer that question, the next endpoint was whether if you had an endoscopy, are you more likely to identify a lesion? And more specifically, are you more likely to identify the common lesions like a papilloma or duct endoscopy, bearing in mind that all of these are benign? You can see from the p-values here that our trial was a negative one. We were not able to show that duct endoscopy actually improved the yield on pathology from being able to identify and localize a specimen for the pathologist. Similarly, we were unable to show that this type of surgery actually made the specimen any smaller. So what were the implications we intend to? Well, we have stopped using duct endoscopy in persistent nipple discharge, randomized controlled trial data to show that there wasn't of benefit. However, it did not negate the technique for visualization of the lesion. And I think the advantage of being able to use the technique for targeting treatments is a proof of principle for people who wish to go down this route. So the direction of travel for papillomas, for example, has been targeted excision of these benign lesions by basket excision or by destruction using laser. We did a second randomized trial, this time looking at patients with cancer. This was only recently published. It was a very difficult trial to recruit for. We can go into the reasons why that is in discussion, but we're going to focus on the endoscopy here. So breast conservation surgery in breast cancer means leaving the breast and removing the lump, commonly called a lumpectomy, more appropriately described as a wide local excision, because you need a margin of normal tissue around your resected specimen that reduces the risk of it coming back within the breast. So excisions have to be complete. And if you had a typical series of 100 patients, 5 to 10 patients of that 100 will come back for a wider margin excision, not because it had been well planned, but because the pathology we know would go beyond the index and target lesion in that proportion of patients. So in this trial, we looked at whether re-excision margins, whether they had to be done or not had to be done, were related to using duct endoscopy as a guide to the position in which you made the cut to determine the resection margins. And again, unfortunately, we had a negative trial. No duct endoscopy group versus the duct endoscopy group had exactly the same re-excision rate. If we look at the endoscopic side of this, of the 34 women who had duct endoscopy, a successful duct endoscopy was only done in 30 patients. So there were 4 technical failures. And most of this is because of not being able to identify a duct to go down at all. So again, an access problem being the main stumbling block here. Of the 30 successful duct endoscopies, 17 identified a lesion. So the ability to identify a lesion is somewhere between 50 to 60%, which was relatively high, I would say, compared to what the unrandomized series were looking at as to how often you could see a cancer-related phenomena when you did duct endoscopy. The highest enthusiasts were claiming 80 to 90%, and more realistic working jobbing surgeons found it was mainly 20 to 30%. So we found it to be around 50 to 60%. But this is what I want to draw your attention to. The tumor was actually only seen in 20%. And everything else that is described as representative of cancer is not actually seeing the cancer itself. The commonest is perhaps being able to see the narrowing or the obstruction of the distal obstruction, but of the duct that is collapsed beyond the tumor. So you can go in the duct from the nipple, it gets progressively narrower until you can't go beyond it, but you don't actually see the tumor. We also ended up in a situation where we described a lot of pre-cancerous pathology in relation to the cancer, but it wasn't the cancer itself. And these were the raised papillary lesions, the atypical changes of flat epithelia that I showed you before. And often these ducts have some chronic inflammation going on in them, and this represents as fibrinous stranding. So even though we were claiming that we could see the tumor in 60% or so of patients, we really only saw them in 20%. And I'm representing this schematically here, whereby we have a tumor in this duct, which has caused this to be blocked. You can't really enter this duct, but if you enter it, you collapse, so you can't see the tumor. But what you might do more commonly is enter this duct here. And if you go into this duct, the duct looks normal all the way, and you can see a bit of narrowing, and you go beyond it, and you can go into that second order duct, into that one, and it all looks normal. So you don't actually see any epithelial abnormality. So to conclude, the concept of evaluating the tumor environment in direct contact with cancer, I think, was a good starting point for the work that we did, and it remains a concept that is valid till now. It's disappointing that the biomarker studies have not yielded predictive or prognostic clinical advantage. And duct endoscopy, whilst a fun modality, was no proven advantage in pathological nipple discharge or in the management of cancer. However, I think it is still a useful tool to access, in particular, benign lesions. And this will, I think, pave the way for targeted interventions, but it depends on what your primary aim of your research program is. Ours was fundamentally cancer-based rather than benign, and the cancer application of duct endoscopy remains obscure. Thank you for your attention.
Many thanks, Mr. Gui, for an excellent presentation, a huge amount of information in a really short space of time. So thank you again. We'll hold for questions at the moment, if it's okay, and
Sure.
we'll introduce the next speaker, and I'm really grateful if you're able to stay for the panel discussion.
Yep.
At the end. Thank you so much.
Great. So it is my big pleasure to introduce Emmanuel van der Porten, who will give us the first glimpse of what robotics can do to achieve endoscopy at minimal scales. Please, I would like to remind the audience before this introduction to write their questions in the Q&A, and we will address them at the Q&A session at the end with all our speakers. Now, as I was saying, it's a great pleasure to introduce Manu, who is an associate professor at the Faculty of Engineering Technology at the KU Leuven in Belgium. He has been there since 2010. He's coordinated the activities of the robot-assisted surgery group in the Department of Mechanical Engineering. Manu has been leading and has been working on a very large variety of European and national proposals, including leading extensive projects on catheter robotics, on eye surgery robots, and on spine surgery robots. He has a mechanical engineering degree from KU Leuven and a doctoral degree from Kyoto University in Japan. I have the pleasure of collaborating with Manu in the context of European projects and UK projects, and I look forward to hearing from him what he has in stock for us. Thank you very much, Manu, for giving this seminar.
Thank you for the kind introduction, Christos. I just want to ask, can you see my screen, Christos? Or
yes,
okay.
You can see it in full slide mode.
Okay, thank you very much. So as introduced by Christos, I will talk about our work that we did in the gift search project, and more in particular on the flexible endoscopy developments that we did in that project. So the background is fetal surgery. As you see here on the slides, maybe I should make this one smaller. Birth defects have a dramatic impact on patient's life. That's clear for everyone. As you see here on this line, you see also the scale of this problem. So 1/3 of the pediatric hospital admissions and half of the pediatric costs are effectively associated to birth defects. And so the idea of fetal therapy is to treat in a very early stage a defect so that the impact of it can be diminished significantly. However, at the moment, the therapeutic options for these defects, treating those are quite limited. So that's actually the background of the gift search project, whereby consortium is working on developing new instruments, new sensors, new fusion techniques, assistive techniques. That's one big part of the project. And the other part is involving the surgeons to validate that and developing new surgical therapies, let's say. And in the project, we're covering a broad range of disciplines and diseases, ranging from twin-to-twin transfusion syndrome until treatment of spina bifida, as you see here. So we have this whole area of diseases. Project is coordinated by King's College London and then University College London. And I'm from KU Leuven, so we are the foreign partner because it's an EPSRC Wellcome Trust funded project. And the other partners that you see here are all clinics, hospitals, and patient groups that are involved, and that is supporting the developments here. So this is to show the scale of the project is quite big. We have a large amount of engineers, but we have many clinicians involved that are pushing us to develop useful technology. So it led to several breakthroughs. I'm just going to give you some highlights of the clinical breakthroughs. So thanks to the support from these institutes that you see here on the right, one major breakthrough was actually the introduction of spina bifida fetal surgery in the UK. So that's a therapy that's now being offered for 1.5 years. And that has been pushed through thanks to gift search. Have been 32 interventions taking place without major maternal or neonatal complications. Another breakthrough is that there thanks to the project, it was possible to provide level 1 evidence of the value of phyto, which is a minimal invasive surgical therapy to treat congenital disc herniation, showing that thanks to such intervention, fetal therapy intervention, we have a significant increase in survival rate. That's what you see here in this table. You see the survival rate goes up from 15% to 40, 20 to 42, 50 to 63. So that's quite impressive. And you also see that there is still some room because many fetuses will not make it even with phyto. So that's from clinical background. I'm not gonna go over all the technical breakthroughs. I'm just gonna say that like there has been quite some improvement in segmentation of the fetal brain, showing that by treating spina bifida, you can have reduced the hindbrain herniation. New imaging modalities have been developed, for example, dual modality photoacoustics. There was fiber optic hydrophones that allow you to track the tip of a needle under ultrasound much better. Also interesting is a large scale fetoscopy data set that has been recently published, and that can be used to all people in the imaging community to try to learn how, for example, a placenta looks like, how to reconstruct it. What my talk is going to be about is about flexible endoscopy, more is in particular about treatment of twin-to-twin transfusion surgery. Here you see a pair of a twin that is actually that survived this condition, but if not treated properly, actually 80 to 90% of the fetuses will not survive. And so that's the reason to do a fetal surgical therapy on that. Therapy includes moving with an endoscope towards the placenta and ablating anastomosis. So that's places where the arteries of one placenta of that supply one fetus from disconnecting those from the veins from the other fetus, so that the circulation, the nutrition that is provided through the placenta to the fetuses is brought into balance. So that's actually the procedure. Moving down with a very small fetoscope with a laser and burning specific locations on the placenta to separate the placentas for these two twins without damaging this placenta permanently, of course. So here you see a view on the scene. It's a minimally invasive procedure. One surgeon is holding a trocar and introducing a fetoscope. Other surgeon is holding, for example, the laser fiber that is introduced through this fetoscope, and all of them are watching to a screen here, navigating through the uterus. That's what you see here. In the case of a posterior placenta, an instrument is introduced, a laser, and is brought at 1 centimeter approximately to the surface. Surgeons try to ablate on the vessels here, keeping the instrument as good as possible perpendicular to the placenta, so that they can have very precise delivery of energy and a very precise ablation, let's say. Obviously, they have to navigate across the placenta to make sure they capture all the anastomosis. And the big problem is that not all the placentas are posterior. You can see here the case of an anterior placenta. Surgeons need to access much more inclined, and they will not be able to actually reach that placenta and those vessels unless if they use so-called semi-rigid endoscope, and even then you can see that it's very difficult to reach that the different sites properly. Complicating factor is the visualization. Here you see a view on that the surgeon has is very small field of view. A surgeon needs to identify which parts are arteries, which are veins, needs to ablate at the connection of those, and also needs to make sure that there are no vein and artery pairs that he or she forgets, because that would make the intervention meaningless. Another issue is, as you can see here to the right, this is the surgeon is paying a lot of attention here on the image, and as he's doing that, or she is doing that, they forget the amount of force they're applying here on the vessel, on the body wall, or on the membranes, to the extent that endoscope may even be plastically deformed, as you see here. That's not a fetoscope, but that gives you an idea of the problem. Obviously, the same amount of force is applied on the uterine membranes, and so one big complication of fetal surgery is that even if the surgery was successful, in 18.5% of the cases, you may have preterm rupture of membranes, and that is mostly fatal as well. Another hypothesis indicates that the axis diameter, so the size of the instrument here, just making the hole inside of the uterus is already a problematic on itself. So it's very important to keep the diameter very small of those instruments. So if you are going to introduce new technology, in this case, a 3 millimeter diameter is like a constraint that cannot be crossed. So a logical step is obviously to consider using flexible endoscopes. You have like very nice scopes that you see here, 3 millimeter, that are used for ureteroscopy to move through your ureter. So those could be used, as you see here. If we want to visualize this red area to the left, well, we can in principle use a flexible endoscope that you see here under echo, and oriented perpendicular to the surface, and then ablate at that point. Problem is, this kind of endoscopes are very difficult to manipulate. You don't have the stability. You need very precise positioning, targeting a vessel, and keep your laser fiber steady at that point, and then you have to ablate. So none of these instruments are actually a good solution. So within this project, we developed a so-called active, steerable, flexible, semi-rigid endoscope. So it consists of a rigid, straight part at one part, and then at the tip, where we don't want to do any damage and where we want to have a possibility to change the orientation, we have a flexible, steerable part. And that's actually the instrument that we want to introduce and that we developed here. So there are obviously quite some challenges if you want to introduce a new instrument in the theater. First is to understand how the surgeons are going to respond to it, how to handle it, design that it can be handled intuitively. Then you need to control it, and then actually you also have to build and design it. So I'm going to talk about all these briefly. So to understand how this could work, we started by building up a virtual reality environment that you see here on the screen, where we invited surgeons to give a try on an instrument that did not exist at that point, to already learn what kind of features would be problematic, what features would be useful. So we did a number of tests in that early stage. And then we moved actually to the next step, whereby we looked at, we want to trying out something in virtual reality is fine, but let's try to see what we can do in reality without still already building our final design. So we started by looking at existing scopes and investigating whether we could adjust those towards our steerable semi-rigid scopes that we were envisioning. So here you see a typical scope from a ureteroscope that offers the image quality that we need. But problem with those scopes is that they need to be handled with 2 hands, and that's something that is impossible in fetoscopy. So the first thing that we did is making that an active scope so that surgeons can use one hand and then push a button or use a scroll wheel to control the distal tip. And so that's a design that we had here, whereby this was realized by having one artificial muscle here embedded, connected to the lever here, and a surgeon would be pushing on a button and then the lever would be moving back and forth. You may wonder, why is that needed? Well, actually, in these fetoscopes, you have a laser fiber that is very stiff and that requires quite some force to manipulate. So if we would put the laser fiber straight in this instrument, the surgeon would need to apply quite some force here on the lever, which would be tiring and in the end make it difficult to control precisely the position of the laser without too much tremor, let's say. So that's what you see here that was built on top of that instrument. So here, this is controlled by this muscle there. And the next step was then to put just a rigid shaft on that instrument so that we actually have turned a passive scope into a semi-rigid flexible scope, as you see here. So we did quite some experiments with that. We found that actually the positioning precision of these instruments is not so straightforward. So we encountered quite some hysteresis in there. You see here a typical pattern of hysteresis. You have an input signal, and then if you change direction, your output signal is not properly following. So there is kind of a delay, and that can lead to overshoots and hampers severely the usability of your system. That comes from several factors, but in general, in flexible instruments, catheters, and you will always have this hysteresis problem. So you have actuation, friction, nonlinear behavior of material, all contributing to this. So then we looked at how to solve that. So one major issue is we have a 3mm instrument. We are not supposed to add too much complexity in their extra sensors. So we mainly looked at, can we have like a feed forwards model to compensate that. So we worked on a so-called modified generalized Prandtl-Ishlinsky model. You can look it up in this paper, showing that it is possible to get a relatively smooth motion if you're applying such feed-forward controller. Here in blue, you see a reference signal. The green is the modified general Prandtl-Ishlinsky response, which is much smoother than, for example, a lookup table that we also implemented. It's not perfect, but a surgeon is in the loop, so he can compensate for that. Advantage is he doesn't see any jerky motion upon velocity reversal, and this becomes a workable system. Now that's the low-level control. Another issue that arises is high-level control issues. You're dealing with a flexible fetoscope. At the distal tip, you have a camera. As soon as you're bending your fetoscope, the angle of your camera changes, and surgeons get completely disoriented. So they even become afraid of operating this instrument because they don't know where they are in space and whether they are, how to retract the instrument from the patient, whether the shoulder is in the neighborhood of a critical structure or not. So they become quite frightened at that point. So what becomes important if you are developing such flexible instruments is that you think of ways to mask this complexity. And so here on the video, you see how we autonomously control this distal tip. We have a sensor inside, and the sensor measures the surface, estimates the normal to the surface, and then based on that, we control the bending angle automatically. And this kind of low-level task is taken over, and the surgeon doesn't need to care about that. Here we cheated a bit because we had a sensor in there, an all-optical ultrasound sensor. In the reality, we do not have that, so we needed to come up with a way avoid that. And so the idea was there, well, we have a camera that is watching the scene. Actually, the camera has a light source, and just like any kind of projection, if you project on side of a surface, as soon as your projection, your light source is not perpendicular to the light source to the surface, you will have this gradient in intensity. And so we trained a neural network to use this information to estimate the normal to the surface, or the inclination of the distal tip with respect to the surface, and use that information to feed that back to our control. So you see here, we try to learn that on different kind of endoscopes with a chip on tip, with a fiber scope, or with a rod lens, and we reached relatively high accuracy with that. And based on that accuracy, we could then add a filter and automatically bend with respect to the surface so that it would remain perpendicular, as you see here. So this is just manually held instruments, and our distal tip is controlled so that it stays automatically perpendicular to the surface. Not perfect, but good enough to properly ablate there. So we validated this further with surgeons. This was in a mixed reality setup, as it allowed us to have a better understanding of the ground truth. So we checked with 4 surgeons, expert surgeons, and we asked them to rank their preference of instruments in this environment. So we compare a straight instrument with a semi-rigid instrument, then a manually controlled steerable instrument, or an automatically controlled steerable instrument. And we asked them to ablate on just a posterior placenta, that's here placenta at the bottom, or a placenta in the middle, or an anterior placenta A here. And we asked them their preference. And you see here on this chart how for the easy placenta at the bottom, surgeons still prefer often the method that they're used to, straight instruments, curved, not necessarily having automatic bending. But as soon as it becomes more difficult, if we're going to middle or top placentas, even die-hard surgeons not used to this new technology indicated to prefer this. This instrument has been built in the meanwhile. This is the instrument that you see here. It has a 3 French working channel for the laser fiber here, chip on tip camera with a low latency image acquisition, an LED and an ergonomic handle. We also have, like here, buttons now, so surgeons can just fire or provide water irrigation with these same buttons. Here, yeah, and it's also built based on pneumatic. This is with artificial muscles in there, so it's a very lightweight instrument, very low cost, so it can be easily replaced or reused, let's say, and thrown away. So here you see the instrument being used in a mock-up, an in silico mock-up of the uterus, watching at the placenta being manipulated, also with the dedicated light source and the targeted ablation fiber. So this system is now ready for animal trials. I hope to introduce the results of that soon. For the moment, I just want to conclude that there will be further need to provide more flexible instruments. And so we will have similar approaches necessary or improved to keep the precision of these flexible instruments to the level that surgeons are used to with rigid instruments. There are extra tricks needed to ensure that they are usable and intuitive in use. And we have to keep everything simple because we need to get those instruments then also through regulation And if we add extra sensors, this may be a problem there. So we would need to try to use as few as possible sensors there. In the end, we have a flexible scope, but actually there is a lot of robotics in there in that scope, so it can also be called a flexible robot. Either way, also through this process, even if we automate part of this, the surgeon will need to have the last word during the entire phase of the design. We have had many occasions that we as engineers were completely in the wrong direction, working in the wrong directions, and where the surgeon feedback was vital. That's a bit the end of my talk, and looking forward for questions at the end of this session.
Fantastic, Manu. Thank you very much. And Martina will now take over.
Manu, thank you very much. A great talk.
Yeah, I might kick off if it's okay. Hopefully Mr. Gui's still there. But I think it was pretty clear from Gerald, from your talk, that I think you said visualization at the moment is pretty hopeless. Do you think that by improving, if there were steps that we could improve the visualization, is that going to make a big difference, or is it really, even if we had improved image quality, it would still be a problem to make a diagnosis down there?
Visualization is critical, and I think it is part of the problem. The other problem is access. Not being able to get into the right duct system is the main issue, I would say. And depending on what you're trying to treat, if you're trying to treat a problem where there's distal obstruction, you may not be able to get to your target. DCIS, I think there was some question on that being a useful medium. I think that is an exciting area. There is already some studies that started, and I'm not sure what the conclusions are because it's suddenly gone quiet, but there were some studies on DCIS by treating DCIS by infusion of topical chemotherapy. And they didn't use ductal endoscopy, interestingly enough. They used ductal lavage on the basis that anatomically, I don't think we've ever proven that the breast segments communicate with each other. And that's a fundamental problem. So, but I think the authors felt that there was a big enough probability if you cannulated, several ducts, that it would get to the target. But I saw that as a feasibility study about 6 or 7 years ago, and we haven't heard anything since then. So I suspect it's all gone quiet. It would be preferable if you could identify the duct and instill, the fluid under direct vision, and then be able to get back to it to see and monitor response. It's interesting to see what will happen if chemotherapy damages the ducts, causes them to collapse, and whether you can go back again, because I don't think that's been done.
Yeah. I mean, it struck me that from Men Long's talk that some of the challenges of getting into more distal branches, I'm not saying it's been solved necessarily, but it sounds like it's definitely moved on for the lung. Is that right, Men Long? And
yes, that's right.
I guess, do you see any crossover there in terms of being able to apply some of the approaches, into different fields, whether it be breast or others, or from your Monarch platform? Or?
Yes. So as I mentioned in my, I think second last slide, like I also so we are now investigating using this platform for multiple purposes, not just bronchoscopy. So one is the GI endoscopy, the other one is the urology. So yeah, we are looking for that. Breast cancer is probably not something we are currently considering now, but yeah, it doesn't mean that we would not check this potentially in the future. Yeah.
I think one of the problems is the size of the scope, though, isn't it?
Yes.
In the breast, you're trying to do everything in a kind of sub-millimeter diameter scope, which is the biggest problem.
Yeah.
I think the other thing that struck me about that sort of seemed to transcend all of the talks was about the force and the potential for force damage. I mean, in Manu's talk, obviously that's a big deal when it comes to a fetus, and the potential for injury in preterm and so on. But so force feedback, is that something that you think in those various applications is it going to be helpful in terms of giving the surgeon a better sense of the degree of force being used? I mean, Mr. Gui presented, you know, that image of the angel hair fibers where it was clear that had gone through the you know, the duct. So could that help? Is that of value? Or
it's a question for me.
I think for all of you, really. Is it? Do you see any value for having improved technology that could give a better sense of force, the you know, the degree of force, and an idea of that, you know, what the critical force would be to cause injury, I guess. Perhaps to Manu first in terms of the fetoscopic.
Yeah, so it would be very important. So currently there is force feedback because the surgeons are actually applying these forces. But what is happening is that surgeons are not so sensitive to static forces. So you tend to apply a force, and after a second or two, you forget that you're applying that large force. And so what would be useful is a system whereby we measure the force and then link that to tissue damage, and then signal the surgeon that it is critical. For example, it could be that is like with an auditory cue or some image, augmented reality, some visualization. Because in this procedure, they need to reach those spaces. So it's not that they have the option not to move in that direction and do the ablation. They just need to move to the direction while keeping the forces low. Right. So one part is indeed force measuring, which is the first ingredient of force feedback. And then the feedback itself may be, in this case, auditory or visual. Right. I think in other applications, it may be useful to have it haptically augmented, like so that it stands out more. I would be happy to hear also the other panels leads comments on that.
So I can talk about bronchoscopy, like using our system when we think about forces. So yes, it will be very useful. And our platform, our robot is a flexible robot. So we have tested before, and it wouldn't damage tissue because it's through tissue inductions. And this is also proved by our 8,000 data cases. So yeah. So, but I would say that force is definitely useful because that can also tell you that how the shape of the lung might have changed during the procedure, and there will be additional information for navigation guidance. Yeah.
Well, so I think in the breast it's very hard because it is two moving beasts. The breast moves and the endoscope moves, and quite a lot of the time you're trying to counterbalance the forces to be able to manipulate the duct into this. And I think, as has previously been said, it's quite easy to forget how much pressure you're applying when all these things are moving. It's also very different when the patient's awake and the patient's asleep. And it's also very different when you're dealing with the kind of model that doesn't kind of do anything apart from, tell you that you've made a hole. So I think the breast poses specific challenges in moving targets.
Yeah, and yet it's fascinating to me. This is mainly, I guess, to Mr. Gui again, that thus far it seems that some of the robotic approaches that we've heard about haven't really penetrated yet, anyway, into the breast cancer space. So I guess the question would be, from what you've heard and what you've seen about improvement in instrumentation and design and so on, do you think we should be going for the better clarification of benign disease and or intervention on benign disease, or do you still see a potential role for it in cancer? Or
it's a tricky one. There used to be a forum that looked at this, and every other year there was a kind of rather niche area that people who were looking at this in the breast would meet every 2 years and update each other on what was going on. And as I alluded to in the talk, it was mainly biomarker driven. And as the years went on, the endoscopists fell off the platform. And I think it's because of the technical challenges that became a point of no return.
Yeah.
I think that technology has improved a huge amount since we had an active program, but I think you can count the number of active units that are doing this on the fingers of one hand. I only know of one center in Europe doing this at the moment.
Yeah.
And it's not in the UK.
Yeah, and I guess, so if you were, and I'm not suggesting that you would now at this point, but if you were to be starting this program again with all of what, this new sort of technology, improved imaging, sensing, and so on, would you aim to go down the route of really boosting the diagnosis of benign to avoid blind surgery, as you really elegantly described?
Yeah. So the problem with that is you've not really shown an application in terms of randomizing for surgery aided by such technology. But what I think is helpful, and again, it depends on whether you want to invest a lot of effort into treating benign disease. And it wasn't really part of our agenda, but it is much easier. It is definitely much easier access-wise, and it is. I think that the center in Utrecht are looking at laser ablation of papillomas.
Yeah, I think Christos was going to come in.
Yeah, so I have a question on the general. Conceptually, the flexible endoscopies, across case is conceptually similar. And what I'd like to ask is, to what extent is this a robotic challenge, or a lack perhaps of having any sort of meaningful sensors to put in the robot, or maybe a combination of both? Like, if you have very poor visualization, then what would the robot do, or where is the trade-off there? And I guess that's a question. Maybe first for Manu, and then Menglong and Gerald. So Manu, what do you think is the challenge, the sensors or the actual robotic backbone to make things smaller?
And now you're referring to the breast case, huh?
In general,
scenario.
In general, to make it, to miniaturize even your device, at what point is it challenging to make the actuation parts, whereas holding any instrument that are relevant?
So I think for miniaturization, like for fetal or for bronchoscopy, as was shown by Menglong, we are close to where we need to be. But I think then for the breast application, there is indeed still a challenge. I think there is opportunities. If you look at instruments for eye surgery, those dimensions come in the neighborhood of what was needed for breast applications. So that's one thing. Then I think mainly, so the controllability of this, having sensors in there, and kind of, there may be a need for some autonomy, because it becomes difficult to navigate, to have an understanding of the entire shape, whether there are contacts. Most of the time we're looking at the tip, what is happening there, and based on that we can navigate, but we don't know very well what is happening along the length of our instruments, and there some extra information from sensors can help to reduce risks, and also for making the intervention more intuitive, because even if you have a very flexible device, it's not always straightforward to know how to steer it and to see that it moves. You have a very good input device, like Menglong indicated, they have a very intuitive console, but the input-output mapping may not be always as fast, because you may have some slack in your channel. You have a flexible structure that you are navigating in along a complex trajectory. So I think there are still some challenges, how to put sensors in there, and how to add this understanding, and take it away from the surgeon, so that he doesn't have to deal with this delay, and can be more dynamic and assertive in his actions. That's my understanding.
So my understanding is that I think it really depends on the application requirements as well. Like for bronchoscopy, physicians used to use those tools like robust ultrasound probe. needle and forceps when they want to confirm the location and take a biopsy. And then these tools, they have a size defined, right, by their own manufacturers. So like, for example, when we develop our platform, we need to make sure the physicians can still use these tools. So we will need to basically design the size of our scope based, at least we make sure the working channel should be big enough to get these tools to go through. So there's a limitation there if we want to make it even smaller. The other thing, yes, as you mentioned, one is the sensors for sure. Like if you like, for example, if you want to put a camera there, definitely you need to reserve some space for the camera as well as for the LEDs. And yeah, for the other sensor like EM or navigation sensor, this can be built not on the tip, like they can build somewhere. You just need to do a calibration there. Yeah.
Know a lot about these methodologies, but the only thing I would say about the breast application is that the small instrument is only one aspect, but it's also having to stay within the confines of the duct. It's not, not just manipulating in a space that is, very small. And I think it might be fine in eye instruments just because of the size, but in manipulating a duct, some of those turns and twists that you have to go, it'll be wonderful if there was a kind of manipulable device, but all of that's going to make the scope thicker, and trying to be able to be able to negotiate that is going to be, it'd be much better, of course, I would suspect, but the challenges of staying within the duct are what I would see as a problem.
If I can ask one more question based on the stuff that we're circulating on the panel. Is there a, first for Manu, I love this instrument that you created. I have to admit I wasn't aware of it, and that's bad on me. I should have known about it. But you touched it at the end. I mean, it's not a robot in the classical sense of things, but it's definitely robotized, it's definitely smart. How do you see these synergies between, using existing instrumentation and making it intelligent and smart, and how do you handle the back and forth design decisions with regards to the surgeons you're collaborating with?
That's a very easy question that you're asking me. So the close collaboration with the clinicians is essential, because we had a virtual reality system. We did experiments with the surgeons. They gave useful feedback. We moved to a real system. The feedback that we got is completely different from the feedback we got from the virtual reality system. And so each time the system goes one step higher, but there is always major changes that we had to take into account. So I don't know how we had a few surgeons involved, like 4 or 5, and all of them have their own opinions, and I'm not sure yet how to optimally deal with that, to be honest. The only thing we can do is maximally deal with them, try to have as many as possible interactions, and then try to find the common denominator among opinions to see what is the simplest device that we can build that still adds value and does not frustrate surgeons. So we had a very robotic approach in mind, and somehow we need to be somewhere in the middle, whereby we kind of leverage their expertise and ours, and find really what is troubling them. So for example, this orientation, this is something that seems very crucial in handling flexible instruments, and where it's not yet fully understood how that is manageable with handheld instruments. I think maybe in a system where it's fully teleoperated, where you can really decouple the input with the output, so it's a bit less of an issue. But here, if you want to stay close to the surgical common practice, it becomes a bigger issue to deal with. So I have no perfect answer on how to deal with it. Sorry for that.
No, I think that's good to speak from experience. And the final question, that's for everybody, really. So, of course, these are systems with human in the loop, both in the case of the Monarch platform and what you have designed, Manu, and hopefully, you know, what would be in breast surgery at some point. But I saw, you know, a lot of modeling efforts, for example, the hysteresis modeling, and to what extent can human in the loop mitigate some of these modeling requirements? And maybe Menglong, you know, you have a deployed product. What's the trade-off between excessive modeling and human in the loop?
Can you say the question again? I think I lost you.
Yeah. So how much modeling inaccuracy can an operator handle before they say, like, I can't use this?
Okay. So that's actually an interesting question. So in our process, we have a thorough pre-planning process defined for the user. We have a software that get the users to plan, first do the segmentation, of course, on the CT, and then plan for the target, and then show the path to the target. And also the user can also go inside that, you know, there's a visual branch view in the software. They can go through that to check, okay, which way they should go. And they can then memorize that in addition to the intraoperative guidance we will provide during the procedure. So yeah, these can, I think, very well define, like they can like make a decision if you're gonna go or not. So, okay, so to answer your question, your question is that in what situation that they might choose not to use the system, right? Is that something that, so, so far we haven't seen too many changes of this yet. So yeah, usually when the physician, when they adopt the system, they've been very happy using the system. And then we found that they don't want to go back to the traditional bronchoscopy again anymore, or to other competitors and products. So yeah, so far, yeah, it's not that something that's very common now. Yeah, because it's the first one and it's also robotic based. They like using the joystick to do the navigation. So, and especially when it provides the capability of reaching the distant nodule, they feel like there's something that's something they can do with the old way. So yeah, they just like it.
Right, and Manu, what's your viewpoint based on, you know, for example, that you showed us?
Yeah, so my understanding is, if you look at so we do some modeling because we have a nonlinear system, and we want actually that there is a good relation between the input and the output. And then this relation can be nonlinear. That's not a big problem, but it should be 1-to-1. So that means that surgeons should see the system moving depending on his or her inputs. So if he's giving a command, move to the right, then he or she wants to see it moving to the right almost instantaneously without too much delay. And that's actually where this modeling, in our case, is essential, because the systems, these mechanical systems, and even if we go to lower dimensions, they will have friction. And so there is always going to be this difference between input and output. So I think also, I'm not sure if it's also included in the system from Menglong, but that's actually, maybe Menglong can comment on that, if there is also some kind of additional modeling included. But that was actually the main issue, because surgeons want to change be in full control. They want to change perfectly, direct the instrument to a certain target, and they will be moving all the time from left to right to have it perfectly in the center or so on. So these changes of direction are crucial. And in our hardware, maybe it's a suboptimal hardware, this is not trivial, and therefore we do this modeling. And then we have advantage in fetal surgery. It's not in contact with the environment, so it's a free space system that makes the modeling a little bit easier. As soon as we are in contact with the environment, yeah, you have forces that also play a role, and so it becomes harder to predict.
Yeah, and I'd like to add, there's also one thing that we can use from sensor, like for example, the camera that we put on the tip in the end, right? So when they are reaching the target, for example, in bronchoscopy, they can, because our camera is always there, and they can use the live view to check how they should move the robot to center or the target they want to biopsy. So this is also one way that they can actively check to make sure it's safe and reliable. Yeah.
Thanks. Martina, would you like to wrap up?
Yes, I think we can wrap up. Thank you so much. It was great to have all these 3 talks. So we discussed about the clinical aspect, the academic one, and the industry one. It was very, very useful. We learned a lot. A big thank you to Mr. Gu, to Manu, and to Menglong. And we hope that the audience really enjoyed the workshop as well. Have a lovely evening, day, wherever you are. And hope you will enjoy the rest of the symposium.
Thank you. Thank you for organizing. It was super.
Thank you, everybody. Bye.
Excellent.
Bye.
Bye.